All right, so the first dysrhythmia I want to talk about is third-degree heart block. Now, this looks really close to sinus brady, but when we take a closer look, I want you to ask yourself, where is the P wave? So let's take a look. There's a one here, there. Look where all the P waves are. They're all randomly spaced apart. Normally, the P is supposed to come right before the QRS, but in this case, the P's are anywhere. Now, that happens because the atrium and the ventricles are not communicating with each other. They're both independently beating whenever they want. This happens often because of heart damage, such as an MI. Now, the main issue with third-degree heart block is the really low heart rate, less than 40 beats per minute. This is going to cause a decrease in cardiac output, which means the heart isn't pumping enough blood out. This leads to hypotension, which is low blood pressure, dizziness, weakness, and syncope, which means the patient can faint. Now, the treatment for third-degree heart block is transcutaneous pacing. Transcutaneous pacing is a fancy way of saying a temporary pacemaker. You want to make sure you put both pads on the top and the bottom of the heart, making a sandwich of the heart. After the temporary pacemaker, we want to get the patient a permanent pacemaker. The next dysrhythmia is called atrial fibrillation. And what's happening in this one is the atriums are fibrillating, which is another way of saying shaking. The atriums, the top portion of the heart, are just shaking instead of beating. So when we take a look at the rhythm, we see that there's no P wave. Instead of there being a P wave, we see this shaking line. Now, if you remember, what is the P wave? The P waves are the atriums contracting. But in atrial fibrillation, the atriums are not contracting, they're shaking. So how that appears on the ECG is a shaky P wave. That's why we see that squiggly line instead of the P wave. Another thing that you have to note is that each QRS complex is irregularly spaced apart. Look at the distance between each R. They're all irregular. Now, the reason AFib happens is because of damage to the heart, because of an MI, heart failure, hypertension. Now, AFib isn't always an issue. Yes, the atrial rate can be up to 350 beats per minute, but the atriums don't provide blood to the heart. That's the ventricles. So if the ventricles aren't beating fast, then AFib is generally not an issue. The next dysrhythmia is very similar to AFib. It's called atrial flutter. Now, when we take a look at a flutter, we see that instead of a squiggly line, we see these P waves, 3 P waves before each QRS. We see P, 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 QRS, T. And this is often described as a sawtooth. A flutter is caused by the same thing that causes AFib, heart damage, MI, heart failure, hypertension. The rate is slower than AFib though, where the atrium can beat more than 250 beats per minute. Now, the treatment for AFib and A flutter is amiodarone, which is an antiarrhythmic medication. They can also do ablation, where they burn the electrical signals that are causing the dysrhythmias. The patient can also receive beta blockers, calcium channel blockers, digoxin, and something called electric cardioversion. This is when we shock abnormal rhythms into normal rhythms. This uses less joules than defibrillating and often is elective, meaning we schedule for it, the patient signs informed consent, and they get a diagnostic procedure called a TTE, or transthoracic echocardiogram. And this is to check if there's any clots inside the atriums before we shock them. The patient is also sedated with medications such as propofol. One of the most important things is that you make sure the defibrillator is synchronized to shock on the R wave. So make sure you press the button right when it lands on the R wave and you don't miss, because it can kill the patient. I'm just playing. There's a button that says synchronize that automatically synchronizes it to the R wave. All you gotta do is just press the button. The last thing you need to know is to make sure the patient maintains an open airway. So AFib and A flutter have a complication, and that's clots. Now, the reason that happens is because the atriums are just shaking. So instead of the blood being pumped out into the lower ventricles, what happens is the blood stays and swishes around in the atriums. And what happens when blood stays in one place? It clots. Now, the treatment is going to be anticoagulants. And the trick to know all anticoagulants is Rin-Ran-Ban. If you know Rin-Ran-Ban, then you know all anticoagulants. There's one specific one that I want to talk about, and that's warfarin. Warfarin is really commonly prescribed, And how it works is it stops vitamin K. Vitamin K is a coagulation factor that's needed to clot, and warfarin stops it. Warfarin needs to build up in the body for it to work. So the lab we get in order to see if warfarin is working is INR. It stands for International Normalized Ratio. Now, normal INR when you're not on warfarin is 1.1. But if you're on warfarin, it should be 2 to 3. This is called therapeutic levels. While the patient's on warfarin, you also want to teach them to eat a consistent amount of vitamin K. And what has vitamin K? Green leafy vegetables. You want to teach the patient to avoid aspirin because this can lead to more bleeding. And the last thing you need to know for warfarin is that the antidote is vitamin K. The other anticoagulants that can be given for AFib and Flutter is dabigatran and rivaroxaban. Look how they all end in rin, ran, and ban. The nursing interventions for patients on anticoagulants are bleeding precautions. And how you're going to remember this is Randy. Randy needs a soft, bristled toothbrush. Randy stands for razors have to be electric. You want to avoid any rectal, so no suppositories, no enemas. The N is for no NSAIDs like ibuprofen, aspirin, or naproxen because these can cause bleeding. You want to decrease needle sticks, for example, IM, subcutaneous, or IV insertions. And the I is for injury. You want to protect the patient from injury. And the last thing, Randy needs a soft bristled toothbrush. A soft bristled toothbrush will prevent the gums from bleeding. The next dysrhythmia is called supraventricular tachycardia, or SVT for short. When we take a look at the rhythm, we see that there's a QRS, but then there's a PT kind of thing. Then there's another QRS, and then there's another PT wave. And what's happening here is that the P wave is actually combined with the T wave. So how you're going to differentiate this from sinus tachycardia is you're going to look for a P and T wave. If the P and T wave are combined, then it's SVT. The reason this happens is because of heart disease, heart failure. It could be genetic. Young women are especially at risk. Now, what happens for SVT to occur is that the heart actually has an extra pathway where the electrical signal can go in. The extra pathway is near the AV node. And when it enters this extra pathway that is not supposed to be there, the electrical signal goes in a circular pattern, causing extreme tachycardia. The rates can be as high as 250 beats per minute. And even though it's very fast, SVT is usually not an emergency. Now, if it does cause the patient to be symptomatic, meaning they have decreased cardiac output, then we want to try some non-pharmacological treatments first. The first thing is massaging the carotid. This will slow down the heart rate. We can also try a Valsalva's maneuver, which is when you bear down like you're pooping on the toilet. It's also called the vagal maneuver. As for pharmacological treatment, it's pretty much the same as AFib and Flutter. We want to give beta blockers, calcium channel blockers, digoxin, and electrocardioversion. There's only one thing that's different, the A. Instead of amiodarone, we're going to give adenosine. Adenosine is a drug that's going to reset the heart. You want to make sure you pick a port closest to the heart and you push it as fast as possible. The next dysrhythmia is called premature ventricular contractions, or PVCs. And when we take a look at the rhythm, we see that it starts off with a normal ECG. There's the P, the Q, the R, the S, and the T. But then all of a sudden, look at that really weird wide thing that's going on there. That's the PVC. And then we go back to normal sinus rhythm. And then look again, another really wide QRS. You're going to identify PVCs by noting that they're wide and bizarre. Usually they're isolated, so by themselves. These wide and bizarre QRS complexes are caused by an MI, hypokalemia, hypoxia, or an increase in the sympathetic nervous system, like drinking coffee. The rate is still 60 to 100 beats per minute, except there's a random PVC popping up once in a while. Sometimes catching these can be kind of difficult because they randomly appear. So to diagnose these, the patient is given something called a Holter monitor. The patient wears this Holter monitor for 1 to 2 days, and you have to make sure you teach them not to shower in those 1 or 2 days because the monitor cannot get wet. Now, generally, PVCs are not an issue, so you just want to document. If you see frequent and recurring PVCs, however, this can affect cardiac output, and the patient may be prescribed beta blockers or calcium channel blockers. The last thing you need to know for PVCs is that they can turn into ventricular tachycardia and ventricular fibrillation. So ventricular tachycardia is when the ventricles are beating really fast. Now when we take a look at the ECG, we see these negative, meaning upside down, QRS complexes. But they're not normal QRS complexes. They're really wide and bizarre, like a PVC, but many of them. We also don't see a P wave and we don't see a T wave. Sometimes I like to think of VTAC almost like a comb, like to brush your hair, but they also look like shark teeth a little bit. Now what causes VTAC is heart damage, just like every other dysrhythmia. MIs, heart failure, hypokalemia, or hypomagnesemia. The rate can be as high as 200 beats per minute, and this can affect cardiac output. Now the treatment varies. If you go to the patient and they have a pulse, then you want to call the doctor for an order for amiodarone, the antidysrhythmic medication, or for cardioversion in case the patient has decreased cardiac output. If the patient has no pulse, then you want to scream and run around in circles because they're dying. I'm just playing again. They are dying, but scream actually is a mnemonic that stands for shock, CPR, rhythm check, epinephrine, and amiodarone. This is how we treat pulseless VTAC, ventricular tachycardia with no pulse. Alright, the next dysrhythmia is torsade de pointes. Now, torsade actually means twisting. So when we take a look at the rhythm, we see the rhythm starts twisting. It goes really long and tall QRS complexes, and then it gets very small, and then very long again, almost like a tornado or a twister. Now, the most common reason why torsade happens is because of QT prolongation, specifically drug-induced QT prolongation. This means the QT interval is prolonged because of drugs, but it can also be caused because of hypomagnesemia and hypokalemia. The rate is very fast, 250 beats per minute, and we definitely want to treat this because this can turn into ventricular fibrillation. Now, the treatment is going to be magnesium sulfate. The next dysrhythmia is ventricular fibrillation. Now, this rhythm is very deadly. We take a look at the rhythm and there's no pattern whatsoever. It's just chaotic and disorganized. It kind of looks like a picture my toddler drew with a crayon. The main causes for ventricular fibrillation is ventricular tachycardia and myocardial infarction. The rate is going to be very fast, 500 beats per minute. So there's no cardiac output whatsoever. Your patient has about 2 minutes before they're dead. What you want to do is scream. So shock, CPR, rhythm check, epinephrine, and amiodarone. Alright, so we've been talking about shocking people a lot with these deadly rhythms. Now, defibrillating or shocking someone involves using electricity to reset the heart. We use about 120 to 360 joules of electricity, depending on the defibrillator. You want to make sure no one is touching the patient and the patient isn't touching anything. You do this by calling out all clear. Once you've done these things, then you can shock the patient. How you know defibrillation worked is the patient is arousable so they can wake up. The patient has a sinus rhythm and they have a stable blood pressure and heart rate. The other part of scream is CPR. The first step for CPR is checking for unresponsiveness, meaning you go up to the patient and see if they're even responsive. If they're unresponsive, then you want to check a pulse. If the patient has no pulse, then you want to begin CPR at 100 beats per minute, making sure you press down at least 2 inches. You want to make sure you give 30 compressions for every 2 breaths and that you check the rhythm or pulse every 2 minutes. The next thing I want to talk about is something called an implanted cardioverter defibrillator, or ICD. This is a surgically placed device that automatically shocks the patient whenever they have deadly dysrhythmias. This is only for critical patients that have ventricular issues. Your job is to know when the heart rate cutoff is, meaning when is it going to shock, and how many shocks it's going to give. The next dysrhythmia is called asystole, and this literally means flatline. So there's no electrical activity in the heart and the patient has no pulse. There's also something called PEA, or pulseless electrical activity. This is when you see electrical activity, but you go to the patient and they have no pulse. The treatment for both asystole and PEA is CPR and epinephrine, not shock. Oftentimes, the media shows whenever a patient goes flatline, you shock, and that's untrue. You want to give CPR and epinephrine. The next dysrhythmia is something called artifact. And when we look at the ECG, we see a normal sinus rhythm, but then all of a sudden we see a lot of electrical activity. This is because they're static. Oftentimes because the patient is shaking, they're tremoring, they're shivering. What you want to do is treat the cause, so stop them tremoring, stop them shivering, or you can also reattach the leads. All right, guys, that's everything you need for dysrhythmias.